I'm Yo-Yo.
And I'm Katia. Welcome to our podcast.
Each week we learn from the experts about all things women's health and happiness.
We are two very normal, imperfect women.
Navigating this crazy thing called life.
And trying to stay happy and healthy while we do it. So, grab a cuppa.
Or tidy away that pile of laundry.
And enjoy our discoveries. Hello and welcome.
Welcome to episode 42.
Yes, thanks for joining us. We
Thank
have
you.
an amazing guest on today's episode. We have the lovely Dr. Carys Sonnenberg, who is an exceptionally experienced GP and works both in the NHS and privately at a clinic that she founded called Rowena Health.
Rowena Health is a private menopause specialist and women's health clinic, and it encapsulates the fundamentals which Carys is passionate about, which is providing personalised, holistic care, giving you knowledge and understanding to support your own health as well as well-being now and in the future, which is exactly what we stand for here in the podcast as well.
Exactly.
Isn't it?
Yeah, 100%. So, she encapsulates so many of our own passions.
Yeah.
And
Although she's smarter than us.
a smidge.
Just me, maybe not you.
Definitely
you'll
me.
hear what we're talking about.
Yes, definitely. Carys is unbelievably qualified in the fields of menopause and women's gynecological health and just women's health in general. And she's part of about every single key faculty that we have and like any college related to women's health. For example, like the British Menopause Society, she's a big member there and talks a lot of their conferences and things like that as well. So, but please look at her website for more specifics because there are so many qualifications that she has.
Yeah, we tried to list them all out, but there's just too many.
Yeah, we had to have about
we
4 takes.
Yeah, we couldn't list them.
Sorry, Carys, you've got too many.
So many qualifications.
But yes, having her on the podcast, it was a complete pleasure and privilege, I feel like.
Yes.
She was incredible.
Yes, and she's it's really interesting. She's currently she informs GPs about women's health, lots of gynecological things, lots of menopause things. She also informs women. She has women who come to her as clients. She is also a bit of a rising star on Instagram and TikTok.
Yeah, she's got an amazing. You'll find it in the interview that she's been asked to be one of TikTok's clinician content creators. So we don't know what that means yet, but she's only one of 20, and it's because of her content is so factual and evidence based, and
super evidence based.
She is very, very good. And honestly, it was just I can't say enough how privileged it was to have her on the podcast and just to talk to her and ask her some questions, because she is a font of all knowledge. Like she's the bridge between like the women and the GPs, as you were saying, that she pulls it all together. It's not just like, about medicines either, it's about holistic care as well, and she's just very passionate. And
she's passionate, but at the same time she only says evidence-based things. Yeah. Like you could tell that she wouldn't say a personal opinion about anything. It was
But she talks about her own personal journey of what, that's different. But she also this is why she's so clever, the amount of like facts she could reel off, and I was just like,
yeah. We're both just sitting here like
how is your brain working and how is it? And then she's just I just was in awe of Carys.
Yes, absolutely. Thank you, Carys, for spending some time with us this evening. We really enjoyed this episode, and I'm pretty sure you, as the listener, are you going to learn quite a lot about all things women's health, and even if you're not approaching the menopause yet,
we talk about periods in general and contraception and symptoms and just general lifestyle, how you can prepare your body for the future.
Yeah, but it's like, even if you're not in that phase, like we're both 35, 36, and we're not really that close to it, but at the same time this is really useful to know.
Like it's creeping around the corner.
It's creeping around the corner, but just to be powered with this knowledge.
Yeah, there's things we can do now.
The things we can do now, but also when it comes, it's not a surprise. We kind of think, okay, these are the kind of conversations we might have with our GP. This is what I can be expecting. So it's really good to learn about.
Yeah. I hope you enjoy it. We learned so much, and I'm sure you will too.
Absolutely. So, without further ado, enjoy the episode.
It's my pleasure. Thank you so much for asking me.
Oh, it's so nice to have you. We are going to dive straight into our first question and get all that knowledge from you today. We were wondering, so our periods, we start when we're in our teens normally, and then until like perimenopause and menopause, do they normally just stay, or do they change throughout your life, or do certain things maybe affect your periods through your life as a woman?
Yeah, that's a really great question. So when you start your periods, that's a word we call menarche, which is where the first start of your period. And it takes about 8 years to reach reproductive maturity. So that means for things to settle down, so your hormones settle. And during that time, initially when you start your periods, you may find that you have some cycles that produce an egg, some ovulatory cycles, we call them, and some cycles which don't produce an egg. So you may find that you have spaces between your periods, sort of long gaps, or your periods may be heavy and prolonged as you're going through puberty and you're just starting off. And that's because the way that the ovaries and the brain talk to each other, so the ovaries produce estrogen and progesterone, and the brain produces FSH, follicle stimulating hormone, and luteinizing hormone, and these sort of talk to each other in a negative feedback loop in order to make the ovaries work and stimulate production of a little cyst each month, and out of that little cyst should pop an egg, and then if you don't become pregnant, then about a couple of weeks later you will have a period, you will have a bleed. So it takes a bit of time for that to get going. And then once it does get going, in most women, you should have a period about once a month. And that's caused by the FSH and LH changing and the estrogen and progesterone. And some things can affect that, like stress, like changing your body weight up or down, like being pregnant will obviously stop your periods. Excessive exercise can stop your periods. So you can have pauses in your periods for certain reasons, and sometimes you may skip a period, and that's okay. But if you are in a regular cycle, you've settled into a regular cycle, you've had your 8 years of settling in, and you suddenly start to find your periods are changing, or there are becoming big gaps between them, it's worth seeing the doctor just to check all is okay, because there are some reasons that are hormonal for changing periods, like if you have polycystic ovarian syndrome, you may not produce an egg each month. You may have gaps between your periods, and we don't want you to go too long between a period. We want to bring on a bleed about every 3 months for somebody with polycystic ovarian syndrome. So we give you some hormone tablets to bring that on. Some other reasons are some women go through very early menopause, and that causes their periods to pause. Maybe if you haven't had a period for more than 4 months, for example, then you may want to go and see your doctor so that they can do some blood tests to exclude that as a cause. It's a very rare cause. Maybe 1 in 1,000 women will go through an early menopause under the age of 40. So it's very unusual for that to happen, but maybe up to 3% of women do in all when we look at it. So there are lots of reasons for periods pausing or changing through our lives. And one thing that we do find is that when people lose or gain body weight, that can affect their period cycle if they've got PCOS, or if they the way that it affects the hormones in the brain, for example, can also affect the period. So there are other causes as well. But usually you would settle into some sort of a regular cycle. And then as you reach so we're born with a certain number of eggs in our body. And as we go through life, we ovulate some of them out, and some of them just shrink away. And we get our egg level declines. And when we get to a certain amount of eggs, then the hormones that I spoke about, the FSH, the LH, the estrogen and progesterone, start to change a little bit. And we may find that some months we ovulate, some months we don't, and the brain is having to work hard to get the ovaries to produce eggs each month. And that's just the start of changes that we might see in the perimenopause period. And that time is the approach to menopause. So menopause is 1 day after your last natural menstrual period. The time after that is post-menopause, and that's the rest of your life. And the time when you start to see changes in your periods, either longer, shorter, longer apart, shorter, closer together, heavier, lighter, and you may start to experience some symptoms of menopause, that's the start of perimenopause. And that period of time can last about 10 years before your ovaries stop producing eggs, stop ovulating, and you are then not fertile anymore, and your estrogen level remains low. And in perimenopause, we see this big fluctuating wild level of estrogen. So it's just the ovaries are preparing to stop, but they haven't stopped yet. So you can have some symptoms that you have with changing estrogen levels, but you're still producing eggs, but it might not be every month, and your periods could become quite heavy and prolonged, especially if you haven't produced an egg for a bit, because you need to produce an egg to make progesterone, and progesterone is one of the hormones that's involved in the menstrual cycle.
Wow.
So lots of reasons for things to change, but in most women, you will have a regular monthly-ish cycle.
Yeah, thank you for explaining that.
That was really interesting. So the 8 years at the beginning, if your brain and your ovaries haven't had that communication, and you start on something like a contraception or hormone kind of contraception, like I went onto the antimicrogynon when I was 16, does that mean that my brain, until I came off it again, is that why sometimes it takes people time to potentially get pregnant because they haven't had the natural kind of communication, or does that not matter?
As far as I'm aware, that doesn't matter.
Okay.
So it's some people. So the combined contraceptive pill, it's a brilliant question, there are now 3 types of combined contraceptive pills. So let's just be clear. So our ovaries make there are 3 forms of estrogen. The most active one is E2, called estradiol.
Okay.
And that's the one that's the one that's most active in our fertile years. So and the ovaries also make a hormone called progesterone, and that is our natural body's hormones. So when you look at the pill, you take a synthetic version of that estradiol, and it's a little bit different, a lot stronger.
Okay.
And they put that into a pill. And when they first made the pills contained quite a lot of that ethinyl estradiol, EE. But because we know that caused blood clots, they had to bring the levels of estradiol down. So now we have levels which are lower than they previously were at the beginning, in the 1960s-ish, when people were originally prescribed the pill. So the pill contains that synthetic estradiol, or synthetic ethinyl estradiol, and a synthetic version of your progesterone called a progestogen. And there are lots of different types of progestogen. Some of them are a bit old-fashioned, some of them are more modern, as it were, when we describe them, and they act on different receptors in the body, and they have different risks. Now, there are also pills now that are newer that contain a factory-made version, which is molecularly the same as your own E2, your own estrogen. Wow. So there's one that's got a more natural estrogen, and there's a new one which has just been released onto the market in the UK in the last year or 2, and that contains E4, which is a version of estrogen that's made in pregnancy by the fetal liver, and it or by the fetus, and it's a different type called E4. So you've got the pills now that contain ethinyl estradiol, the old-fashioned one. You've got the ones that contain E2, and you've got the ones that contain E4. So, and they all are mixed with a synthetic progestogen, which is a little bit similar to your progesterone, but not quite the same. So there are lots of different types of pill, as we call it, known as the pill. And there are 2. So the pill is a hormonal contraception. You can have the pill mixed, so the estrogen, one of the 3 types of estrogen and a progestogen, or you can just have a progestogen on its own. That's called the mini pill, and that's a progestogen only pill.
Yeah.
So you can actually take the combined contraceptive pill, the estrogen and progestogen, from early on in your cycle until you are 50. Some people take it on a standard regime where you would take it for 21 days and then have 7 days off. Some people take it on a tailored regime where you shorten your 7 days off or even skip your 7 days off. And it depends why you're taking the pill. So if you have really terrible migraine in your 7 days pill-free interval, then you might want to shorten that. So if you're taking your pill, combined contraceptive pill, and you're taking it in perimenopause, then the estrogen part of it may help your symptoms. And if you have your pill hormone-free interval, you might find your symptoms start to come back. So maybe you want to shorten it. The Faculty of Sexual and Reproductive Health have got some brilliant guidance for doctors about how to use the different types of pills, which types of pills contain what types of hormones. There's one that contains varying amount of hormones in the month. So when you're taking the pill, if you choose that as a method of contraception, you've got to be really clear on that it's safe for you, really clear of what its benefits are and of what its risks are for you, and of what to do if you forget it, or you're late, or you vomit within a couple of hours, or you have really severe diarrhea, or you're taking a medication that could interact with it. So there's some really clear guidance on there about how to safely prescribe and what sort of things to look out for if you have the pill. If you're taking the pill and suddenly you develop really severe migraine, for example. So there are things that you would need to be aware of, that you need to know, okay, I need to go back to the doctor now because I wonder if this is okay. So if you choose to take a pill for your contraception, then it's a really great method of contraception, and it can be used also to treat, to manage conditions like endometriosis. But you need to be able to remember it perfectly. So if you remember it perfectly, it's got a failure rate of about less than 1%. But if you, in normal life, we know that it has a failure rate of about 9%, which means that if 100 women are given the combined pill for 1 year, 9 of them will become pregnant whilst using it. And usually that is because they've forgotten it, they're late, maybe they had bad diarrhea, they didn't realise, maybe they took a medication that interacted with it and they didn't realise. So those sorts of things are really important. It's a brilliant method, but it's just got to be really careful you take it correctly.
Yeah. Okay. Well, I didn't realise either as well it would help with some perimenopause symptoms. So if you didn't use it for contraception, it could actually kind of help through perimenopause as well. Like, so if some people might not realise if they're continuing it using contraception, may not have those symptoms as much as they would have done.
Yeah,
I didn't realise that.
absolutely. Yeah, it is because it contains the estrogen, so either the ethinyl estradiol or the E2 or the E4, though that estrogen can help to lessen the symptoms of perimenopause. So if you were taking it in your 40s, for example, and it was safe for you to do so, there's a big list of ways that we need to work out using that specific guidance about whether we're okay with that for you. If you were taking it, then it may well help your symptoms of perimenopause. But if you come off to have your little break every month, every 2 months, every 3 months, or maybe you take it continually, depending on what your doctor has advised you to do, then you might find your symptoms return during that time. But it can be a possibility for people who want to look at a method of contraception in perimenopause, which you do need. Even if you're skipping 6 periods in perimenopause, you still need to use contraception. So all women need to use contraception until we're 55. Everyone can stop then. Very unlikely that we're going to become pregnant after that. But if you are if you're having your natural periods and you stop your period for you need to use contraception for 2 more years if you're below the age of 50, and for 1 more year if you're above the age of 50. So it depends sort of where you are when you stopped your periods. If you have something called polycystic ovarian insufficiency, which is where you, in essence, have the menopause before 40, you still need to use contraception with that. condition because there's about 5% chance of pregnancy with POI, or polycystic or premature ovarian insufficiency. It's not called premature ovarian failure because the ovaries are not failed. There is still a chance of ovulation, but it's about 5%. So it's important that we advise people who have that condition that if they don't wish to become pregnant, they do need to continue using contraception.
Yeah.
Oh, I hadn't even thought of that. Which is,
Interesting.
it's really interesting.
Yeah. You've spoken a lot about the pill. I'm curious, do you have any, do you know anything about research, or what are your opinions about any links with taking the pill for a long time and perhaps incidence of breast cancer? Because I don't know much about the actual science behind it, but I've heard people mention things like that. What's your take on that?
Yeah, having looked at the research, there is research that links the pill. So the pill has got various benefits and risks. So breast cancer, there may be a small increased risk. So we would look at that particularly on prescribing. Ovarian cancer, the risk is reduced.
Okay.
Endometrial cancer, the lining of the womb, the risk is reduced. Cervical cancer, the pill can slightly increase your risk of having HPV, which is the human papilloma virus that is checked for on using your cervical screen. So we advise that you have regular screening. If you're taking the pill, it's really important you go and have your cervical screening done. It's not anything to be concerned about. But so the risks and benefits are there for using the pill in different ways. And if somebody had active breast cancer, we would not give them the combined contraceptive pill or history of breast cancer.
Okay.
So there are these guidelines called the UK MEC guidelines. They are extremely long and detailed, and they look at risk of prescribing, so safety of prescribing for contraceptive methods. So not just the combined contraceptive pill, but also the progesterone-only pill, the implant, the depot injectable contraceptives, and say on a press. And they also look at the different types of coil, little T-shaped devices that fit inside the womb. So they give us really detailed information on whether we are safe to prescribe, and it's really important that we look at those when we are prescribing, because everything comes with risk and benefit, and what you want to be sure of is that the choice that you are making is the benefits outweigh the risks. So it gives us guidance on levels 1, 2, 3, and 4. And at level 4, you wouldn't prescribe. Level 3, you may not prescribe. Level 1 and 2, you are going to be more happy to prescribe.
Okay.
Oh, wow.
So often things are much more complicated than you think. So it doesn't just come in a black and white picture. It may be that somebody's tried lots of other things, and we need to consider what the safest method is without putting them at risk. So lots of guidance for us as doctors to make sure that we do that correctly.
I suppose it is, you're playing like cocktails with like everyone's so different with just the different hormones and their levels and how they work, different factors. It must be like, it's not as you said, it's not this is good for you and this is good for you. It's so personalised in a way.
Yeah.
That's exactly right. So I've had two lovely ladies in clinic today where we've ended up with choice of things to do. And there are often lots of things that we could do, but it's trying to find the best one. So we'll say, this package will give you this benefit and this risk. This package will give you this benefit and this risk. Which one shall we go for? And that's what shared care is now. When you're looking at going to see a doctor who's really knowledgeable in a field, they will often give you choice. So it's not the old days where someone used to say, well, here you go, this is it, and this is all you can have. So now you have an opinion, you have an ability to share information, and something might really matter to you. So therefore, we've got to take that into account. So I might say to somebody, well, this is what I would advise. And they might say, well, actually, I really don't want to stop what I'm taking at the moment. So how can we work with that? So that's what the discussion is all about when you're looking at really evidence-based medicine. You're looking at studies which are good and well conducted, like randomized controlled trials. We often base guidance on because we know we can be a bit more sure of the evidence. If you're looking at trials that are observational trials where you're just looking at people being watched over periods of time, you don't really know whether that evidence is secure enough for you to base guidance on. So we need lots more research in women's health to help us be sure that what we're doing currently is correct and safe and the best evidence-based medicine, but we can only base our guidance on what evidence we currently have.
Yeah.
And we still have lots of trials, I think, that need to be done in women's health in order to help us guide women better with more support, and we can be a bit more sure that we know of what is happening. Because, for example, the hormone replacement therapy hormones that we use now are different to the ones that were done when studies were done in the past. So the ones we currently use are different. We start women on hormone replacement therapy at different times from the studies that were done in the past. So can we extrapolate data? Well, it's debatable, isn't it? Because we're using different types of hormones in different ages of women. So we just need to know a bit more about that. So there's lots of information that we now need based on the strengths of hormones we give, based on women, based on what age we use it in, and their risk factors and things.
Yeah.
So it's interesting.
Yeah, it's really interesting. We hope you're enjoying this episode so far. We'd love to help more women out there, so please subscribe, rate and review, which helps more people find us. And share this episode with any friends who you think will enjoy it too. Thank you. And without further ado, here's the rest of the episode.
So you went into this topic of HRT, hormone replacement therapy now, and I was very interested to ask, after all this chat about the pill, contraceptive pill, going on to more of thinking about pills for perimenopause instead. So back in the day, I think there was a bit of controversy about HRT. People were worried about the safety, but I think thoughts are changing a little bit. Are they? Could you maybe explain a bit how you professionals like you are looking at HRT at the moment?
Yeah. So HRT is hormone replacement therapy, and it is given to women who are having to relieve menopausal symptoms. And you can prescribe it in somebody who's having symptoms in perimenopause and if they are in menopause. And it involves adding back estrogen. And if you have a womb, or for example, if you've had your womb removed for endometriosis, or another reason, you may be asked to take progesterone or progestogen as well. Estrogen thickens the lining of the womb. It's like a fertilizer on the lawn. And progesterone or progestogen is like a lawnmower, keeps it nice and thin. So you don't want a big thick womb with heavy bleeding. You don't want any risk of abnormal cells or cancer developing. So you want to have a nice thin womb. So progestogen is estrogen and progestogen if you have a womb, or for some women who don't, come together as a package. You can't miss your progestogen. Some women need to have testosterone added to their HRT, the hormone replacement therapy. Some women use vaginal estrogen, which goes up inside the vagina as a little tablet or as a little pessary or some cream or gel or a little plastic ring. And that is really super low dose estrogen, and that helps with those vaginal and bladder symptoms that women can experience as their hormones change in perimenopause and menopause. 80% of women will suffer from these symptoms. So you may need to pee more often, you may have urine infections, you may have a little leak on the way to the loo because you're trying to dash there. And the vagina and the clitoris and the vulva can shrink, and the tissues thin by about 2/3, and they become itchy and sore and dry, or maybe a bit wet, and it becomes less acidic. So we like it to be lovely and acidic down there. There's lots of lactobacillus, which is a healthy bacteria that helps keep us safe and healthy down there. But when estrogen falls, that environment changes, becomes less acidic, and the tissues become thinner. And so if you have sex, it can tear, it can bleed, it can be really sore, and women experience a lot of pain. And lots of women don't talk about this because they find it embarrassing and they don't know what's happening to their body. They just think it's a normal part of aging. But we can help with estrogen going inside the vagina. That's a really super low dose treatment. It can be used by almost every woman. If you're taking aromatase inhibitors for breast cancer, then you may need to seek advice from a specialist, and you may need to try non-hormonal moisturizers first and lubricants. So lubes come in two things: they're oil-based, water-based. So you put one on your partner, one on you, and that mimics the natural lubrication you would get having sex. So there's ways to make things much more comfortable. So the hormone replacement. So the studies that were done 20 years ago were done in older women with an average age of 60 plus, and they were done using conjugated equine estrogen. So remember the estrogens I've spoken about already.
Yeah.
So we've spoken about ethinyl estradiol in the pill. We've spoken about E2, estradiol, 17-beta estradiol, which is E2. That's our most active one that's released by the ovary. We've spoken about E4, the one that's released in pregnancy by the fetus. And it doesn't use fetuses, by the way. It's a synthetic version of that. So it's not, in case anyone's worried, it doesn't use that. And there are also other types of estrogen. There's estriol, which is E3, and there's estrone, which is something produced by the fat cells. So there's lots of different, mostly after menopause. So that's a weaker one. So there's lots of different types of estrogen. It's not just one. So the estrogen in the studies that were done 20 years ago was conjugated equine estrogen, released from the urine of pregnant horses. So that's where that came from. It has an entirely different risk profile than the E2 natural estrogen that comes from our own body. They also used different types of progestogen. So remember, that's the synthetic version of your own progesterone. And they found when they originally published the studies before they were complete, and it showed an increased risk of breast cancer. So many women stopped taking their hormones at that point. Then the study was completed and really looked at in detail, and the evidence showed the risk wasn't as big as they had considered before the study was published. When you do a study, it's really important you do it correctly, and it's really important you analyze the data before releasing it. So now we use different hormones. So we use E2. We very rarely would use the conjugated equine estrogen. Maybe somebody who's older, who's been on it for years and doesn't want to come off it, might be on it. And we often would use a body identical progesterone version. So it comes in a little capsule. You take it orally. Some people with medical guidance can take it vaginally. And so the hormones are entirely different in their risk profile. And when we start them, it's also different. We start them generally in women who are a little bit younger. So we start them in perimenopause or in early menopause, and we know the benefits. It is more beneficial to start your HRT within 10 years of your menopause, because you then see that you can reduce your risk of cardiovascular disease, heart and blood vessel disease, and you can also help protect your bones from osteoporosis.
Oh, really?
Yeah.
So estrogen has benefits, and it also has some risks. So if you take estrogen on its own, it may slightly increase your risk of breast cancer. If you take estrogen and progesterone as part of your HRT, a new study has been done called the E3N study, which is a French study, and it looked at different types of progestogen and risks of breast cancer with different types. So everyone was given estrogen and people had different progestogens, and it saw that there is a difference with risk. So it saw that potentially observational study, remember I'm saying, so different types of studies, that's an observational study, showed that it was potentially safer to take micronized progesterone in the little capsules, or dihydrogesterone, which comes in an oral combined formulation of HRT, than the other types of progestogen. But this was just for the first 5 years. So after that, we need more data. So there's different types of data depending on what you look at, and but the data seems to show that estrogen on its own, if you're replacing it, may not increase the risk of breast cancer. Maybe there's a small risk, but estrogen and progesterone or progestogen is more likely to increase the risk of breast cancer. But the actual progesterone or progestogen part seems to have an effect upon that. So we've also got to take into account, when we look at breast cancer risk, what your weight is, because fat cells produce a different type of estrogen, which can have an impact upon your risk of breast cancer. Whether you exercise, that will reduce your risk of breast cancer if you take moderate intensity exercise regularly. Whether you smoke, if you smoke, you will increase your risk of cancers. If you drink more alcohol than one large glass of wine or equivalent each night, that will increase your risk of cancer. So you can look at your lifestyle as well as the hormones, and also your family history. So if you have a really strong family history of breast cancer and ovarian cancer, for example, you may need to be referred for genetic screening so that you can check to see if there's a genetic reason for that. About 5 to 10% of breast cancers are caused by genetic problems. So that means a faulty gene like the BRCA, BRCA, which comes as sort of a 1 and 2 most commonly, and that can increase your risk of breast cancer. And if you're carrying that gene, you will be advised of what the best route of treatment is for you. So there are lots of other genes that are impacted, can be impacted upon family history of breast cancer. That's the most commonly known one. So if you have someone in your family, like your great granny, who's had breast cancer, then that's unlikely to increase your risk of breast cancer. But it is still someone in your family, so you could still say you've got a family history of breast cancer. But there is some specific guidance with when we look at somebody as whether they are low risk, as in having a baseline population risk of breast cancer, so about 1 in 7. So if we look at 7 women together, the chances are one of them will get breast cancer through their lifetime risk.
Yeah.
So, and we can help ourselves by making healthy lifestyle choices in order to help to protect ourselves. But sometimes you may have 1 or 2 members in your family that have breast cancer, and you may be referred to clinic and told you've got moderate risk of breast cancer. And that would mean you just need to have some regular checks, so mammograms more frequently. If you have high risk of breast cancer, you've got quite a few members of breast cancer in your family, you're given a high risk, then you'll probably have more testing. So you may have different sorts of tests, more frequent mammograms, and you'll be under a clinic just to check that things are okay. And if you have an inherited breast cancer, like a faulty gene, then that's about 5 to 10% of women, then you'll be given specific advice about what to do. So that's sort of the way it goes. We all start to have mammograms when we're 50 to look at our boobs, to sort of squash them in a little machine, and then they come out to make sure they look at the information and make sure everything looks good. And if it looks like there's a little change, they will bring you back and just check that out.
Yes.
So we all have a risk of breast cancer. We can increase it by making helpful lifestyle choices, and we can also decrease it by doing that. But people develop breast cancer who are very healthy and have very healthy lifestyle choices. So some of it just comes down to genetics and to other reasons, of which we are not sure yet.
Yeah.
So HRT can slightly increase the risk of breast cancer. There may be a very, very tiny association with ovarian cancer. One observational study was looking at that. It can affect things like thyroid function, so we would check that out. You can still take HRT, but it may affect that. Epilepsy can get worse around perimenopause, so adding hormones might affect that. It might affect the gallbladder. You can take HRT in tablet form, oral, and lots of people are able to take that. The pill, the combined contraceptive pill, slightly increases your risk of blood clot. Your blood clot risk is about 2 in every 10,000-ish. It increases as we get older, but as a young woman, say 2 in every 10,000. So taking the combined contraceptive pill can increase that, and taking oral HRT can increase that very slightly. So if you take HRT through the skin as a gel, you'd rub on your skin the estrogen, or a spray, or you stick a little estrogen patch on your bottom or tummy, then that absorbs in that in healthy women in moderate doses of estrogen has not been shown to increase risk of blood clots. So evidence we have shows that taking HRT through the skin doesn't do that. And there are also small risks of stroke, stroke is very unusual in somebody less than 60. So we just want to make sure if we're prescribing HRT, we're giving it in the safest way for you. There may be some risks, which your doctor will discuss, that are individual to you. There may be benefits depending on when it's prescribed, but it's the most effective way of managing your menopausal symptoms.
Wow.
But in perimenopause, don't forget the combined contraceptive pill, because we've got those 3 different types of estrogen, and more research is going to be coming about the newer types, so the ones with the E2 and the E4, so that we can watch this space and wait for more information about that. So we have lots of options hormonally to look at.
Yes, that's incredible. Like, it's actually really positive message, because HRT, in my mind, when I heard it a lot, like 10 years ago, was just one thing I thought it was, but it's actually an umbrella term for so many different varieties that it actually could work for anybody.
Yeah.
If you look at what they need, it's just finding what works for you.
Yeah.
Oh, you've hit it. You've hit the nail on the head. It's so individual. I see women in clinic, and every single woman is individual. Everybody has slightly different response to the hormones. Everyone needs a different type of approach, and it's just incredibly interesting how we're all so individual with how we respond to these, how we absorb these. Some people need higher doses, others just need a little tweak. So, it's really, really interesting.
Yes.
But I think people shouldn't be worried about going to see their doctor to talk about contraception, to talk about the pill, to talk about different types of hormonal contraception. There are risks and benefits, of course, but it's really important you understand what they are and that you're happy with your choice and that you're really informed. There's a brilliant website called the Brook Contraception website. I love it. It's so pictorial and it's really great for all of us to look at the different pros and cons of contraception, how to take it, what it involves. There's little videos. It's brilliant. So definitely something. I recommend it to all my patients. It's so nice to look at and so easy. It's not. It's just full of colour. So yeah, really, really great.
Lovely. I'm curious. I come from an exercise background, so I'm an exercise teacher. I love, and on this podcast we talk a lot about exercise as well as a very important thing for health and happiness for women. And I have heard other people speak about perimenopause and hormone replacement therapy. An opinion I've heard is actually you're talking a lot about the pros and cons. There's extra risks, but then there's benefits cardiovascularly, bone density wise. I have heard there's also benefits for muscle mass and say ability to do exercise when you take the right kind of hormone replacement therapy for you. And in my mind, I'm curious about that kind of outweighs potentially some of the risk for breast cancer because you're able then to maintain muscle mass, maintain physical activity levels, your bone density and all of that, cardiovascular health. And like you said, with lifestyle, those are all positive things you can do to offset your risk for breast cancer. So what's your thinking about that?
I agree with you. So the evidence shows that people who do moderate intensity exercise can reduce their risk of breast cancer. And that's also really important for people who have experienced breast cancer and have a history of breast cancer. So we're looking to reduce risk of recurrence. So exercise has so many benefits. Benefits for mental health, for example, particularly if you do it outside. It's got benefits for your physical health. And also in the way I describe exercise, there are 4 ways. So we look at aerobic exercise, so you get that bit of hot and sweaty. So we're looking at maybe 150 minutes a week divided into chunks of doable things. So it's interesting, isn't it, when you look at what people guide to be the best way of exercising, whether we should be doing HIIT therapy, whether we should be gently walking. So I think moving the body is really important. We're all coming from a different place. Some of us are marathon runners. Other people are just gentle walkers, so moving the body, keeping active is important, but it is really important to do that and actually to try and progress things so that you're not just simply just strolling with a dog who likes to sniff every leaf and you're not going to get much exercise going on there.
Yeah.
But it is important to do that. We're also looking at strength because we lose muscle mass from our 30s, so we don't want that to go. And it's actually quite hard to keep your muscle mass maintained unless you are lifting weights or working against resistance. So obviously we're all, again, coming from a different place. So we need to build that up gradually, but progressive strength training is important. It will help to protect your bones. It will help to your metabolism because muscles suck a lot of glucose up out of the blood. So when we go through menopause, we see metabolic changes. So we might see our blood lipids rising, so blood cholesterol and our bad cholesterol, LDL. We might see we become more insulin resistant. So that means that we are the insulin is something that helps blood sugar go into the cells. That's released from the pancreas after we eat something which contains, say, a sugar, for example. So if we're resistant to insulin, it becomes more difficult for us to balance our blood sugars, and we may gain weight because insulin's our fat storage hormone. So if we're insulin resistant, the levels of insulin may increase and encourage us to gain weight around the middle, which isn't where we want our weight to be stored, because it increases our risk of metabolic syndrome, or sort of diabetes and high blood pressure and cardiovascular disease. So lots of things happen to the body, and remind me where I was going with this now.
Exercise, strength training, building muscle
strength
mass.
training, yes. So strength training is important for that reason as well, and also it will help with bone mass. So we don't want to develop osteoporosis. 50% of us as old ladies will fracture something. So if that's your hip, or if that's your wrist, it's going to significantly impact upon your quality of life. And actually, if you do fracture a hip as an older lady or man, you have about a 30% chance of dying within the year. So we really don't want those fractures. We want to protect ourselves. We also want to work on balance so we don't fall over and fracture our hip. So actually practicing balancing is really important at all stages of our life, and particularly as we get older, when it isn't as easy as it was. And also practicing your pelvic floor exercises. So those are the muscles that hold you up, hold your bladder and your bowel and your womb inside you, and keep it up. So we want those to be nice and strong as well. So there are 4 ways that we need to be exercising always through our life, just to keep ourselves strong. So when you're young, you need to be really exercising, using weight-bearing exercise, because that's when you're building your bone mass. You want to get as high as you can, so that when it does start to reduce, you're coming from a good level. So you're less likely to get osteoporosis.
Yeah.
And you do that by being active.
Yeah. Okay. And potentially the same can be said for muscle mass as well, because
course.
with age, muscle mass does reduce, or it's more difficult to hold on to it. So the more we build it earlier on, we start from a better level potentially.
Yeah, you're so right. Yeah, all of the being active as a child and being active as all the way through our lives is excellent. So the people that I see, and I genuinely see, in having done 27 years of general practice, the people that have done that are well for longer are those that have exercised.
Yeah.
Regularly exercised.
I was going to ask you, because you mentioned pelvic floor exercises then, but you also mentioned that in perimenopause and menopause, we have more bladder issues and more needing to go for the wee. We need to go for wees at different time and need to rush to the toilet. Is that, and you mentioned it's because the hormones and the thinning of the, is it the thinning? Is that right?
Yeah.
Is that
so the vagina?
Yeah, because I always thought it was because the pelvic floor was weakened, but actually there's also a menopausal impact of it as well. That's why later on in life.
Yeah, you're so right. So both things will impact. So estrogen has effects everywhere in the body.
Okay.
So temperature control, it affects your mood. So you might find you have irritability, anger outbursts, low mood, anxiety, difficulty concentrating, loss of joy, brain fog, where and loss of memory, loss of words. So that's how it affects your mood and brain. It can affect your gut, causing reflux symptoms, irritable bowel syndrome type symptoms. It can affect the bladder and the vagina, as we've spoken about. It can affect the skin. And so the layers of the skin that make collagen, for example, estrogen has an effect upon that. So that's why when you start to notice estrogen changing, you may notice a change in your appearance. So you lose subcutaneous fat under the skin, and you're more likely to gain it around your middle. But also you lose collagen, so things become a bit droopy. So you find things, and that goes for the pelvic floor. So you may find that becomes weaker. So you are more likely at that point to have had children. You may not have done your pelvic floor exercises because maybe it wasn't something you were doing. And maybe you've had an operation. So lots of women who've had operations, maybe a hysterectomy, may struggle with their pelvic floor as well. So a pelvic floor physiotherapist. So there's the app called the Squeezy app, which reminds you to do your pelvic floor exercises. There's also a pelvic floor physiotherapist, which you can access from your GP, or on my website there is a link to somewhere you can find a pelvic floor physio. They are so helpful at helping you. So many people I see in clinic manage by jumping into a bush, getting up 3 times a night to go for a wee, always leaking. So they have these almighty pads that they need to sort of absorb any leaks. When they go to the gym, they might not do the star jumps because they know they're going to leak. So, bladder symptoms are a real problem for lots of women. And often, strangely, even though I put my questionnaire for my menopause clinics very detailed, and sometimes people score 0, but when you really ask, they are really struggling with the symptoms of bladder, but they haven't really wanted to talk about it because they feel that it's something they're not ready to share. So it's really important that we talk openly about these things. So we know what things can trouble us, we know where to get the right help, and we don't need to wait for it to become terrible before we do.
Yes. Yeah.
Amazing. I wanted to clarify that will all help with the pelvic, with the bladder incontinence as you go through menopause as well, with the pelvic floor.
Yeah.
Because it is something that, even after having children, everything feels a little bit like, well, obviously not as strong. And if there's more hormonal changes to happen, then the benefits of just starting that now are like going to help me further on if I keep doing my pelvic floor.
Yes.
It's not just
Pelvic floor is really important.
Don't ignore your pelvic floor.
Often you might do it when you are, you're sort of cuddling your baby or something, and then after a while you forget, and then you don't do it for years. So it's something that we need to keep really super healthy. So concentrate on those 4 types of exercise, and there are lots of things we can do to prevent. If we're looking at keeping ourselves healthy, we can exercise, prioritize sleep, make sure we go to bed, and make sure we give ourselves 7 to 9 hours in bed to get that sleep that we need. Make sure we don't drink too much, that we reduce stress. So that's a really important thing for us. Our cortisol level may rise as we get older, so we don't want to add that further, and stress can impact upon all parts of our body. And socializing and learning a new skill. So women often, when we go through perimenopause or menopause, we might start to forget things, and it's very frustrating for that to happen. You're trying to remember a word, or you're trying to remember something, and you just know that it isn't going to come. So therefore we might stop trying, but that's not the right thing to do. We must keep trying, keep practicing, keep trying to remember things. Because when we have, for example, if you were to meet me and you were trying to remember my name, first of all, you've got to register my name. Then you've got to put it into your working memory. And your working memory hasn't got that much capacity. It's got a bit. So within a few minutes, if it's in your working memory and a few other people come into the room and you're meeting all of them and everyone's introduced themselves, you might have forgotten my name within a few minutes. So what you've got to do is try to put my name into your deep memory, as it were. So you've got to try and think, maybe say it a few times, maybe write it down, maybe associate it with something that you know. So it then goes into your deeper memory so you can retrieve it. And under stress, for example, it's easy for us to try to put lots of things in our working memory and then forget them, and then we get worried about our memory. So the ways memory is a really interesting thing, but lots of people in menopause worry about memory because they're worrying they're getting dementia. Dementia is very unusual under the age of 64. Some people have it in their family. But we can reduce our risk of dementia by using our brain, learning a new skill, by practicing Sudoku, by reading out loud, by doing things that are really going to push the brain out of its comfort zone. We also need to socialise. It's really important. Being lonely is a real risk factor for lots of things as we get older. And all these other healthy lifestyle pillars. We need to be feeling really positive and having a positive outlook. So there are lots of things we can do with our lifestyle. We can manage our conditions like high blood pressure. We can manage our diabetes well. We can make sure that we have as good health as possible in order to protect our brain health. And we need to look at more evidence as to how hormones have an impact on that. There's lots of work being done by Lisa Mosconi and other people who look at the impact of hormones on the brain. So we're learning a lot at the moment about that. We don't take HRT at the moment to prevent dementia. There's no evidence that we can reliably do that. So you'd have to treat a lot of people in order to prevent one case of dementia. So that isn't the guidance at the moment for using hormone replacement therapy. So there's lots of evidence we need.
This might sound a really daft question. So after your menopause and all these like symptoms you've had, and if you've been training your brain, does it and trying to like remember things, if you've put all these into practice, does it then kind of level out and all calm down a bit after the menopause? Because it seems like it all comes like kind of back.
Often women in perimenopause will experience loss of words. So they, if you listen to the work of Professor Pauline Mackey, who is amazing, from America, she talks about there being maybe a loss of 1 in every 16 words. And that's quite debilitating if you're having a conversation, if you're thinking how many words I'm saying, and if one of them, isn't coming, I'm trying to remember it, but it's just not there. And we also find that ways to improve that might be to treat our hot flushes, to sleep well, to reduce alcohol, reduce stress, eat a Mediterranean diet, the healthy things that we can do. So whether HRT helps with that in perimenopause, there are no official good trials, but women do often say that it makes a bit of a difference. But gradually, it will improve in most women through their perimenopause to postmenopause. And that will be done by our brain maybe using, instead of it will use the hippocampus, it will start to use the prefrontal cortex and also start to use the other side of the brain as well. So we will naturally adapt, and most women find that their memory comes back. Women particularly who are well educated, well nourished and in good health.
Oh, that's good news.
That will happen. So it's in fact, personally, that was something I really struggled with in my own perimenopause, because I just couldn't remember anything. So I would have to bring my phone with me everywhere to write everything down in every conversation. And I wondered whether I could work, and it was really difficult. And really upsetting for someone who really loves to learn things, to find I couldn't do that anymore. I couldn't concentrate on reading anything because I couldn't get past the first sentence. But I just kept trying, and I just kept working, and I kept thinking, well, if I read it 10 times, I will remember it. And that's what happened. I didn't give up with it. I just kept going. And actually, it gradually got better over time. Yeah. And I would say my brain's a lot better now than maybe it was before. And nutrition is also really helpful. So making sure you've got good nutrition, and your genetics will play a part. But most women do find that things just gradually improve. So when I heard Professor Pauline Mackey speaking at the British Menopause Society conference about this, I was really relieved personally for myself, but also really nice to be able to speak to women about that.
Yeah.
Yes.
So there were some brilliant podcasts that will look at it. But she's done one for the International Menopause Society, which looks specifically about brain fog. And it's very reassuring. So it says, if you can't remember where you put your keys, then that's quite common. But if you look at your keys and you don't know what keys are for, then that's a problem. And you're also looking at a family history of early dementia, for example. So it's something which is a big problem for women who are trying to work. But the good news is, for most, it does get better.
That's good news.
I already struggle with brain fog and finding the right words now.
But I do think for you that could also be sleep deprivation. Yeah. We're in the stage where we're not, with younger children, we're not sleeping quite enough than for our brains.
True, yeah.
But I have a couple of questions that have been in my mind for a little while. I just want to get them out before I forget them. A while ago, you mentioned collagen levels reducing naturally in the body because of the lower estrogen and the skin thinning.
Yeah.
Things like collagen supplementation. What's your opinion on that?
Well, that is a really good question. So I've just spoken to Dr. Mandy Leonhardt. I did a live interview with her on my Instagram. She has written a book about skin and hair changes in menopause. And we talked exactly about this topic, because we were looking to see what is the evidence for collagen supplementation in, for aging, for example. And the evidence is very limited. So what she suggested was, if you're on it and you feel well on it, you can take it, but there isn't really any evidence that it will help.
But the evidence is limited because maybe it doesn't exist, or is it just there is evidence, but it's kind of didn't make a difference?
I think that it's both.
Okay.
I think there's not much evidence. The studies have been done by potentially by the companies that make the products. So you've always got to look,
Yes.
see.
Yeah.
And the studies are short term. At least the evidence I had was for that. Now, that was the discussion that we had on the podcast, and she has done a lot also on the live interview, and she's done a lot of work in this area. So the book to buy is Dr. Mandy Leonhardt's book on skin and hair changes, so that you can find out more about it, because lots of things do happen with skin and hair.
Oh, definitely. We'll be reading that one.
Yeah, I did see that on your Instagram. It's in my Amazon basket to buy. Because it does look really interesting. Yeah, because
Really excellent.
because it is one of those things that supplements just seem to be everywhere now for like aging, menopause.
Now that is really interesting. So yes, lots of things have got menopause label on them, and then they can charge more money. So so it's really important when you're looking at supplements to think, do I actually need these? What's the evidence for them? And would it be better if I saw a dermatologist about my skin rather than taking all these things? Because actually collagen supplementation can be really expensive, and an appointment with a dermatologist isn't as expensive as a whole year on taking collagen supplements. So so you need to be really careful with what you're believing you're seeing on social media and on the television, and you're reading about things, because it has become a market that that is certainly being growing.
Yeah, it's a hot
that's
topic.
probably the word I was thinking.
I'll say it. It is definitely being exploited.
It's a hot topic. Yeah. And I was also, well, thank you before for giving us such a good review about exercise and about different types. Very personally, have you, throughout your menopause journey, what was the type of exercise that you felt helped you?
So walking, without a shadow of a doubt. I did do some strength exercise. I did lots of sort of weights, not massively heavy weights, but sort of low intensity weight exercise, which was good. But walking really helped my mental health, and it really helped my physical health as well. I also did some higher intensity exercise like cycling and running, but actually that wasn't what my body really needed. I probably didn't give my body enough time to repair and to rest, and actually a mixture of all of those things. But I found the things that help with my mental health really helpful.
So we just have a few questions left. Have you got any pet peeves about how perimenopause, menopause, or anything about women's health is portrayed in the general media or perhaps social media?
So I don't tend to get involved in the discussions on social media that involve opinion.
Smart.
Because and the reason for that is because I want my accounts to be very factual. And interestingly, TikTok have just set up a creator clinicians council, and they've asked me to sit on that council. There's only 20 doctors.
Wow.
So it's a role I'm really excited about, because they were looking for accounts that people were teaching, clinical evidence-based medicine, that were not, and that they could, so we can all get together and we can find out what the role is going to be about. So you won't see on my account, oh, my opinion on this is, or so I will only ever teach in a positive way using evidence that I know to be backed by evidence. So, and I usually teach by guiding people to certain websites that I know are trusted, so that what I am saying is backed up by evidence that I know they can look into more. It's not my opinion.
Yes.
And I think the difficulty that we have on social media and now is that people are often sharing their opinions, and someone might hear that opinion and feel that that is right for them. And people are giving each other advice on their health on social media that may not be quite right for that person. So I feel that we need to be very careful with what we're sharing on social media, and that we're making sure that we're giving advice to people, to women, that's not individual. So everything that I say on any podcast can't be construed as medical evidence for each person. They need to go back to their doctor to find out whether that's safe for them. So I think it's difficult when you're hearing misinformation about things that maybe people who are vulnerable are listening to and taking action on. I would suggest that's probably it. So I always would stay out of that. So if there's any discussion or opinion to be had, I try not to get involved, because I don't feel I don't really like confrontation, and I feel that by providing good evidence-based medicine, hopefully people find your account and then they trust what you say, and then they are more likely to make decisions that are best for them because they know where to get the good information from.
Yes, smart.
Yeah, that's so clever, so important, and that's why we wanted to start this podcast, is for the right information to hit the right people, and not it could be so mixed and everyone's so individual. It's really important that people just get the information they need for themselves.
From people who know.
From people who know
the evidence. Yes, wonderful.
Yeah.
That's amazing.
Fantastic.
Well done on that appointment, though. That'd be incredible on TikTok.
Yeah.
Well, it will be really interesting to see what it involves. I'll have to go to TikTok in October to meet the other people that are doing it. I started teaching on TikTok just some really basic evidence, little reels.
I love it.
I'd never been on social media 3 years ago. I'd never been on Instagram, or I'd never done anything. And then my children are teenagers, and my son was going, well, why don't you just do a TikTok reel? And then I learned how to do it, and I just posted it, and off I went. And one of the reels was watched by a lot of people, and then there were lots of people commenting, and it was just really interesting. So I try now to answer as many of the questions as I can, usually through guidance. Say, look, I can't give you direct advice, but this leaflet might be something you want to take to your GP. Yeah. And that's sort of the way that I've done it. So the most important thing is that we support GPs in being able to care for their patients well, that we educate them if they need that, because we all need education. Things are changing so much. Don't forget, as a GP, sort of a few years ago, we were all told, the same as you were, that HRT was a problem and was going to put people at risk. And then suddenly there's this big boom in menopause, and not everybody GP is as knowledgeable at menopause as some will be. As others are knowledgeable about pediatrics and some cardiovascular disease and palliative care, and we have a huge role as GPs. So we must support our GP, and we also must support the relationships that patients have with their GP, because for some people their GP is the only person they do talk to. So it's really important to positively support both sides. So education for GPs, education for women, so that we all learn together in a way that's right for us all. Yeah. I think that's really important. So if that's something that this role can support, I'm really excited by that.
Fantastic.
Yeah, that's amazing.
So speaking of all that social media business, where can our listeners find you? What's your handle? Because I think you're quite active also on Instagram, aren't you?
I do, so yes. So Instagram is Dr. Carys Sonnenberg. I've got 2 accounts, but that's my main one.
Yes.
And then my website is Rowena Health, www.rowenahealth.co.uk. And there's quite a lot of information on there with articles that I've written, that I've learned about. And those articles will link to other websites that I think are really great and give lots of information. So, for example, migraine. The article I wrote links to the National Migraine Centre, which has got loads of information on there. So just getting people, giving people information so they can find out more themselves. Yeah. And take that information to their doctor, because there were some brilliant things out there that maybe I've discovered that someone else hasn't, and I'm happy for people to share things with me. So that contraceptive one, the Brooke contraceptive one, is brilliant. So that's there, and I've got accounts on LinkedIn. My TikTok again, I think, is Dr. Carys Sonnenberg. So hopefully people can find me there, and I will be doing some more reels. And it's great to have ideas for reels as well. So people often will say, well, please, can you talk to me about this, or can you do one about that?
Or maybe I'll send you a few ideas.
Yes, you're very welcome, Sher. I'd be delighted to help you with that. Yeah.
Your reels are amazing. If anyone's not seen your account, they're so palatable and straightforward, and you come away like, oh my gosh, I now feel informed, and you want to go and research into what you're talking about even more because of what you said.
Thank you.
Not like it's not like too much bamboozled. It's like, right, okay, now
Yeah.
I'm really interested in
It's
that.
very good content.
Thank you so much. Yeah, it's hard to get it right, and sometimes, I don't do any dancing or singing or any of those things. I'm definitely too old for that.
Oh,
I don't
you
think
don't
you
have
need
to.
to. I think it's easier to listen to you. You're very,
Yes.
the way you speak and the way you come across, and the information that you give is so on point. It's not too much. It's not, it's not too little that everyone's confused. And you direct. It's direct. It's brilliant.
Yes,
I was
well
like,
done.
I love watching them.
Oh, thank you. I'm really pleased. Thank you so
And we'll
much.
make sure to put all the links to your website, the clinic, and all the Instagram handles in our show notes, so
and on our social
listeners
media.
can
Thank you
easily
so
find
much.
that.
Thank you.
And people can come if they're in the UK or on Zoom. Do you do Zoom through your Rowena
Yeah,
clinic?
so I have a clinic online,
Yeah.
and I have a clinic. I can see patients in Guildford in Surrey, but I might see people from anywhere in the UK. Yeah, you have to be on the UK soil for my insurance to cover
Okay.
that. And currently it's just me, although I'm going to be working with a lovely lady who is going to be joining me in September, who's just lovely. So there's another doctor who is very similar, because I want to, at Rowena Health, provide holistic care, which means that it's not just all about hormone replacement therapy. It's about the whole. You're looking at really how you could improve your lifestyle, and other things that you can do that will help you. So it's not just about that. So usually people I see for about an hour, and we talk through everything, and it's a really lovely time. So you really get to know the person and listen to what's really troubling them and guide them in the right direction. And then they may come back to see you. It may be somebody only sees me once, and then I can write a long letter to help their GP manage them ongoing. Or it might be that they come back and have their follow-up care with me. Whatever they choose to do is fine by me.
Can you
Perfect.
prescribe them things if you? Yeah, as well. Yeah.
Yeah, so I can prescribe hormone replacement therapy or contraception. Usually, so menopause is such a wide-ranging thing because estrogen receptors are everywhere. So it may be that they need to have further tests done, and it may be that we need to just help guide their GP on what things might be helpful. But GPs are really good at knowing those things. It's just sometimes people, essentially, they will usually come to see me privately because they want to have time, and they want someone to really listen to what's been happening. Maybe things haven't been good with their HRT, and they want to talk about changing that. Maybe they want to know whether they should start HRT. Maybe they are right at the beginning of their journey and they're not ready even to accept their hormones are changing. Or maybe they're post-menopause and they're struggling with symptoms of the bladder and the vagina, and they don't really know how to make that better. So lots of different questions can come with each menopause consultation that are really interesting, and just everybody needs that little bit of support. So it takes a long time to write the report because often we try and give lots of information and guidance just to make sure people have as much as they need.
That's incredible.
But it's tremendously rewarding,
Oh,
really
I can
rewarding.
imagine.
But it's
Wonderful.
incredible though that it's so detailed for people.
Yeah.
Well, it's nice. I think if people are paying for a private appointment, it's really important to give them as much as you can
Yes.
offer in one appointment,
Yes.
because it's expensive and menopause isn't really covered by insurance, although some insurance companies will pay for it. So often people are coming because they don't know where to turn. And when someone comes to you and that's the case, then it's really important to listen for as long as they need, and really important to have the tissues if that's necessary, and really important then to help them understand their body and to help them understand the ways that they can help themselves, and also the ways that you might be able to tweak hormones if necessary, or other treatments, acupuncture, non-hormonal treatments, all the complementary. And I also have some lovely links with a lady who does homeopathy, and with some herbal medicine specialists, acupuncturists, reflexologists, hypnotherapists.
Oh, lovely.
So people that I've kept my eye out to look to see what people are doing.
Yeah.
And I've contacted people, and I only refer to people I've spoken to. So nutritionists, I've got some wonderful nutritionists, genetic people who can work with genetics. So whatever you need, I can usually find someone that will be helpful, and that's really an expert in that field, pelvic physio, psychotherapists. I really learned from early on that this was certainly something, it's a team thing.
Yes.
And everybody needs a little bit different.
Yeah.
So that's what I think is helpful.
Fantastic.
Wow.
Maybe as a final question, because you want to let you go get on with your evening, in your very personal experience, now this doesn't have to be medical, or it can be, but in your own personal view, what does health and happiness look like?
So, my personal view, health and happiness is having a positive outlook on life. Social connection is really important. I really believe we have one life and that it's really important to make the most of every moment. Lifestyle and enjoying your experiences and having things that you can look forward to and are excited by, and looking at the things that someone posted a really beautiful thing on social media which said, instead of "I have to wait for the train today," you could say something like, "I get to wait for the train today." So it's a positive thing. You're here, you're alive, you've got this experience. Although it might be something that's dreary, but you still get to do it. And
Yes.
and
Yeah.
that's it was a lovely way of framing things which actually make life really exciting. So I love different experiences. Since in perimenopause, I've loved spending time on my own, actually, not a lot of time because I love being with people as well, but also really enjoying, mindfulness. I really have taken up taking pictures of flowers and nature,
Oh,
and
nice.
I got this wonderful video of a little bee the other day just rubbing its hands together. And
Oh.
as there are things that you can concentrate on. Really appreciating the moment you're in and that you get to be there, which I think is just amazing. So I think health and happiness is a brilliant podcast title,
Oh,
and I
thank
think,
you.
good health. My mum will always say your health is your wealth, and that is so true, because if you have good health and you concentrate on doing things which can help you with that, then really it gives you opportunities to do all the other exciting things that you do get to do while you're still here,
Yeah.
which is
Yes.
exciting.
Yes, thank you.
Thank you. I just want to ask one more question after
Oh,
that amazing summary, because we spoke to you off air, and we only ask to recommend a book to our listeners, and you have mentioned Dr. Is it Mandy Leonhardt, her one,
Yeah, so one other one I'd love to recommend is Wise Power,
Rice Power.
by Alexandra Pope.
Ah.
It's it's a little bit of a spiritual book. I listened to it on audio after my perimenopause, and it was really wonderful to look at how she explained that period of time, and how it all made sense. Looking back, thinking, goodness, that was so incredible to listen to, and I really needed to listen to it. And I first heard her talking it was a course I went to. It was like a natural menopause course, and it was a time where, if I'm honest, I was thinking, should I listen to this or should I get a cup of tea? And I thought, okay, I'm just going to give it a couple of minutes. And within 2 or 3 minutes, I was in tears, and I was just thinking, goodness, this lady is incredible. And she spoke, and I just glued to my seat for the whole time. And I thought, I've got to listen to her book. And I was at the right stage of my life to listen to that book. And it was really beautiful. And it just shows how you need time in perimenopause to look after yourself and be kind to yourself and retreat and understand yourself while you're going through these hormonal changes. And it was just wonderful. So
Oh,
it's
lovely.
a bit, I think you need to be at the right time of life to listen to it. And I'm not sure what that time is, but
okay. All right.
but I recommend it.
Thank
Oh,
you.
amazing.
Yeah,
And
great
also,
recommendation.
and also, you're writing a book.
Well, my book, yes, it's very. My book's called Women's Health Made Easy. It's
Yeah.
going to be for GPs. So currently we're doing it, and we're looking at different chapters, how to, contraception, menopause, different premenstrual syndrome. So it's going to be helpful, I think, for women and for GPs, but certainly to help things become easier, because as a GP, there's so much that we have to manage, and it can be really difficult to get the information in an absorbable way that means you can learn everything that you need to learn, because it's such an incredible job, such a brilliant job, but it's hard. So I think it's hard to know enough to be able to help people well. So hopefully this book will be able to do that.
Oh, that's
Oh, I'm
exciting.
sure.
Well done.
Well done. And when are you going to publish this book?
So hopefully it will be next April, but
Okay.
it may take a little longer.
Yes, it's a
Well,
big job.
I'm not sure. Yeah,
Well,
yes, it is.
whenever you do have a good time frame for publishing, you can come back on the podcast and just remind everyone.
Yeah, we'd love to have you
that
back.
this
I'd be
book
thrilled.
is
That
coming
would be
out.
so lovely.
Yeah.
Yes, I would. Yes, it's wonderful. Thank you both.
Thank you so much for coming on. We've really
Thank
appreciated
you.
your time.
Oh, it's my pleasure. My pleasure.
Thank you.
Lovely. Well, enjoy the rest of your evening.
I will. You too.
Bye. Welcome back, everyone. What did you think?
I don't even need, you know that
Yes.
I've been loving that.
Mind blown.
Yeah. I'm going to take a few
Knowledge bomb.
days to process all that information. But
I'm not going to sleep tonight. I'm just going to be like, reviewing all this knowledge in my brain.
Like from the offset of just periods in general, I was like,
yeah,
from start to end, it was just, but such a positive like kind of discussion. Like sometimes these kind of conversations can feel quite, they're going to be quite heavy and things like that.
Yes.
But actually, no, I was like, wow.
Yeah, it was just getting all the facts, getting the kind of pros and cons, and this is the type of drugs that are available, but in a very positive way. Like it's not like, oh, it's all like side effects and drugs. It's like, actually these ones will be really good, but there's like the pros can outweigh the cons in these situations.
But the running theme of the whole podcast and everyone's health and happiness is it's so individual.
Yes.
And that was just summarised perfectly in this whole thing. Everyone's individual. You need to just learn as much as you can and go and find the things that work for you.
The running theme, everyone's individual. Another running theme, exercise is good for you.
Breaking news.
Yay! Who knew?
But we'll dissect a bit more in our weekly waffle this week. So come back and we'll be talking about a bit more about the things we learned and what we found was really interesting and what we'll be doing in our own lives. Yeah. And then just catch up of what we've been up to.
Absolutely. Because I think it's been long enough. You've listened to us for long enough. Thank you so much. And we're going to release you.
Yeah. See you on Thursday.
See you Thursday.
Thanks so much for listening all the way to the end.
If you'd like to get in touch with us, you can email us on hello@healthandhappinesspodcast.com.
Or we'd love to connect with you on our Instagram, Facebook or TikTok pages.
You'll find the links to all our socials and more on our website, www.healthandhappinesspodcast.com.
And lastly, before you go, please give our podcast a rating and a review. It really helps others find us.
See you next week.
Bye.